Okay, so is that my cue to get started, Ariana? I can go?
Yep, absolutely.
Great. Hello, everybody. My name is Erica Monasterio. I'm a family nurse practitioner, and I have been working with young people for about 35 plus years. I was at the University of California, San Francisco in the Division of Adolescent and Young Adult Medicine, and also the director of the Family Nurse Practitioner Program for many years, but retired 3 years ago. So I'm delighted to have the opportunity to talk with you all today about working with youth in foster care. This is a very short presentation for a very enormous topic. So we're going to really kind of try and hit the high points. And then I'm going to be introducing you to some resources and materials that we're developing with the National Center for Youth Law and LA Rep that you'll be able to utilize in the future. So I want to just start by saying, you know, young people need services that are really designed for them. And the World Health Organization has, I'm sorry, I'm trying to get this off the middle, but I haven't figured out how. Hide thumbnail video. There we go. The World Health Organization has developed an approach, a framework for adolescent-friendly health services. And you can see here, I'm not going to read them to you, but they've really identified 5 pillars: that services be accessible, acceptable, equitable, appropriate, and effective. And for youth in foster care, we are focusing on these 3 pillars. Services need to be acceptable, which means that the services that you're offering, adolescents are willing to obtain. They need to be equitable so that all adolescents, not just particular groups, are able to obtain the health services that are available. And they need to be effective, which means they have to be the right health services provided in the right way to make a positive contribution to the health of young people. So we're going to go through these 3 pillars and talk about some of the components there, what they mean for services to youth in foster care, and a couple of approaches that you may want to try in making sure that your services meet the needs of the young people that you're working with. So when you see these little quote boxes, these are actually from listening sessions that we've done over a couple of years with youth in foster care and with the young people who are part of the Youth Advisory Board for LA Rep. So that's what these quotes are. And I am going to read them because I think they really tell the story. I wouldn't really reach out to my doctors to talk to them or anything because they would say everything to your foster parents. And I just wouldn't want them to. I don't know, see something or judge me or, you know, just that was my experience, shared one youth. And another young person told us, I didn't get to choose what group home staff went with me when I would go to these clinics. And that was pretty crucial because it was an individual that I felt I was already disconnected with, and going to the clinic was so personal. And then they're receiving my chart or my medication or whatever I'm supposed to be doing after the fact. That conversation, even though maybe it was supposed to be confidential, it doesn't always really land confidential. Getting back to the facility or going back to the group home and them giving them, the other staff, the rundown of what's going on with me. So you can see that young people, and these are not just young people in foster care, young people in general are very concerned about their confidentiality. Confidentiality in services is one of the key issues in providing services to all youth, and particularly for young people in foster care. So acceptable services for youth in foster care are services that are confidentiality conscious in both policy and practice. And I want to really emphasize that it's not just policy. It's how the policy is implemented. And it's not just practice. You really need to have policy because you need to take the time to really think it through and think about what are the services, how are we delivering them, how do we protect young people's confidentiality. So you need, for starters, to know consent and confidentiality rules when you're treating foster youth. So All youth, regardless of their dependency status, have very particular rights in terms of minor consent and confidentiality for sexual and reproductive health care. And this is probably information that's familiar to you. I'm not going to read it to you, but take a minute to glance at it. So minors in California of any age can consent to some sexual and reproductive health care services. And you can see that under at any age. And then minors in California at the age of 12 or older can consent to the rest of these services. So in general, when you're working with youth, they have you can see very broad consent rights in California for sexual and reproductive health care. But in addition to that, youth living in foster care have special sexual and reproductive health rights and protections. So they have the right to access care on their own consent, just like any other young person in California. And they have the right to confidentiality as it relates to that care that they have consented to, just like any other young person in California. They also have the right to privacy in the examination by a provider, unless the youth specifically requests otherwise. So I don't know what your roles are or how you see young people, but I can share in my own experience as a primary care provider that I have on multiple occasions had the accompanying individual with a youth in foster care, let's say a group home staff, say to me, oh no, I have to be in the room. It's, I'm required to be in the room with this young person during their exam. And that is not actually the case. The young person does have the right to privacy. They have the right to age-appropriate medically accurate education and information about sexual and reproductive health, and this is written into the law in California. They also have the right to choose their own provider for sexual and reproductive health care as long as the provider accepts their payer source. So what that means is, let's say you are a social worker, or you are a foster parent, or you are a group home, and you have a clinic that you use. Okay, we always use this clinic, or we always use this doctor. This is where we take all our kids. Well, your clients have the right to choose their own provider. If they want to go to a Planned Parenthood, or they want to go to a different provider, or they want to go to a provider and not tell you, that is all within their rights. They also have the right to transportation by a caregiver, a group home, or a social worker to obtain their sexual and reproductive health care in a timely manner. And sometimes that means there's a short turnaround time, and that transportation needs to be available to them. They have the right to obtain, possess, and use the contraception of their choice, including condoms, without any interference by their caregiver, their group home, or their social worker. And they have the right to maintain that contraception, including condoms, in a private storage space. So even if they're in a group home and somebody else holds their meds and distributes their meds, if it is birth control, they have the right to keep it in their own space, and it's private and it's theirs. And they also have a recourse. So they have the right to make a confidential complaint to the California foster care ombudsperson if they have concerns about any violations of these rights. Now, you might wonder, with this long list of rights, how would foster youth even know about them? Well, on an annual basis, young people who are age 10 or older, their caseworkers are obligated to inform them of their rights, to give them information about how to access sexual and reproductive health education and services, and to assist them in addressing barriers that come up for them if they request any help. Additionally, caseworkers must ensure that they receive comprehensive sexual health education that meets state standards, and that's at least once in middle school and at least once in high school. And because many youth in foster care have pretty unstable placements, they often move multiple times with it during their adolescence. They may change schools. They may miss that week or class or semester where the school they were at is delivering comprehensive sexual health education, which is, again, the law in California. So if they don't receive it in school, then their caseworker is responsible for making sure that they receive it someplace, and that it's an appropriate course with adequate and science-based information in the community. So this is a long statement from an all-county notice that went out to case management workers from the California Department of Social Services. And what I want to emphasize to you, I'm not going to read it to you, but you can see the bolded part. So it sort of lays out that youth in foster care do have reproductive and sexual health care rights, that they have consent rights, and that information must remain confidential between them, the youth, and their provider. As such, a medical provider cannot share a youth's protected health information with a third party, such as the youth's child welfare social worker or a probation officer, without the youth's written consent or a court order. So this is an issue that comes up often for healthcare providers. You know, who can I share information with? We know for our adolescent clients who want confidential services that we can't, without their permission, share with their parents. Well, youth in foster care have those same protections, and the information cannot be shared with a third party without their consent. So this comes back to the issue of both practice and policy. There are many places where there are breaches in confidentiality, common areas that we find breaches. Things like appointment making and appointment reminders. So if you're a healthcare provider working in a system that has an automatic reminder system, that can really blow somebody's confidentiality. If that robocall comes in, someone else answers it and they get a reminder about a medical appointment that the adult in the home doesn't even know the youth had. Confidentiality breaches, as I mentioned before, do come up with accompanying adults during the clinical visit. And again, often the accompanying adult for youth in foster care will say, I'm required to be in the room, I have to stay with them. That is not the case. And they, just like other accompanying adults, family members, parents, guardians, can have the youth's confidentiality rights explained to them, and then they can be invited to wait in the waiting room while you see the young person privately. Another area where breaches often occur is the completion of the health contact form, and I have a little picture of the one that's used in, I think it's still used in LA County. And if you're a healthcare provider, or you work, if you're a foster parent or a case worker, or a group home worker, you're probably very familiar with this form. This is a form where we report back to the guardian what happened in the visit. So often healthcare providers feel obligated to fill every box. We're kind of conditioned to fill the form, and don't realize that we are thereby really breaching the young person's confidentiality. So when it's confidential, that form can be filled in with confidential. Where it says diagnosis and treatment, you can put confidential. Medications prescribed, confidential, so that information isn't shared without the youth's consent. Many follow-up procedures also result in breaches of confidentiality. We call to see if the young person made that appointment at the specialist, if they got to the abortion clinic, if they picked up their form of contraception. And so you have to be very careful that you've clarified with the young person how to contact them, what to do if you can't contact them. Make sure you have their phone number, their email, so that information does not go to the wrong person. And then, although many people assume that all youth in foster care have Medi-Cal, not all do. And so there can be issues with billing and explanation of benefits. So the next pillar, the next big issue is that it's essential to provide equitable care. And equitable care is inclusive. It's based in cultural humility. It's explicitly anti-racist. It's LGBTQ sensitive, and also neurodiverse inclusive. And I want to point out that it was the Youth Advisory Board that, in reviewing materials that we were developing, that's who told us, make sure you talk about the fact that everybody learns differently and that you need neurodiverse ways of teaching young people, sharing information, etc. So here's what they told us. There's a lot of racism in the world, especially in the medical field. I think pushing forms of birth control, just forcing people like, oh, just take this birth control, even though you don't know about it and you know what it does to your body. You might have a heart attack because you smoke cigarettes too, but oh well, at least you won't have a baby. So you can hear this real lack of confidence and trust in that statement. Being LGBT, sometimes you aren't seen as equal and sometimes are teased, and that causes unhealthy choices. So making sure that your services are inclusive. I've had a couple of doctors and I always see if their energy is good. And depending on that, I might open up. It's all about the approach. If you don't approach me right, or I feel like I'm not welcome, I won't feel comfortable or I'll feel embarrassed. So inclusive care really requires a whole system approach. So starting with cultural humility, which I believe probably is a concept that's familiar to most of you at this point, you really need to start with self-reflection. We all have biases. We need to really explore how our own biases and experiences shape how we treat and practice with young people in foster care. We need to make sure that we educate ourselves about medical mistrust and the history of medical abuse of Black, Indigenous, and people of color communities as an aspect of historical and racial trauma. And we need to carefully reflect on the words that we use, the actions that we take, the nonverbal communication that we communicate. Are we making assumptions about sexual orientation, about gender identity, gender expression, about the young person's sexual history or their sexual behaviors? You don't know unless you ask. And you won't hear from the young person. You won't get answers to what you ask if they don't feel like you're actually there to listen and that you're not being judgmental or bringing your biases into the room. So this young person says, I had to ask the group home staff for an appointment because the group home knew where we were supposed to be all the time and controlled all transportation. I was not allowed to make a doctor's appointment for myself. So these are some of the barriers that young people are up against. There are many structural barriers that can really get in the way of sexual and reproductive health care for youth. There are logistical barriers like transportation. There are practices that really actively infringe on the youth's rights and access. For example, not allowing the youth to see the provider of their choice for their SRH care. There's inconsistent access to comprehensive sexual health education and care due to placement change, something we mentioned before. And there's often a lack of policies and training, and that can lead to agency and caregiver fear as well as confusion about what young people's rights are and what their responsibilities are and what the caregiver or agency's responsibilities are. The best way to reach young people is by including young people in your planning, in your development of services, and always checking to see how you're doing. So one approach is to develop, utilize, and support a youth advisory board. LA Rep has had a wonderful experience with the youth advisory board. We have learned an enormous amount from the young people that we're working with and working for. And being a member of a youth advisory board can be a really empowering experience for the young person. And it also very definitely serves to enhance the quality and appropriateness of services for youth. So if you're involved in delivering health services for youth, you really want to think about developing a youth advisory board and utilizing it so that you get the information that you need, get the feedback that you need, and can make the appropriate adjustments to how your services are delivered. Another really wonderful approach is a health navigator program. It's ideal if you can recruit near peers who understand the lived experience of youth in foster care. So this might be youth who are non-minor dependents who are over 18 but still in the system, or young adults who have aged out of the system. Some clinics use health professions, students or trainees. That's another potential source for navigators, but though they really do need then training on what is the foster care system like, what are the experiences of young people in foster care. And that's also true for near peers who have the lived experience. They have their own experience, but they still need the background to understand what the general experiences may be and what the options are. Navigators can be used to reduce barriers before, during, and after the appointment. So making a phone call to the young person before the visit, just to check in, see if they have any questions, make contact, make a connection. And then during the visit, the navigator, they're not necessarily going to be present during the exam, although if the youth wants them to, they can be, but they're present before and after to make sure that the young person understands what's expected of them, that they've had the opportunity to ask their questions and get them answered, that they understand the answers to the questions. Navigators can be involved also in post-visit follow-up, so checking back with the youth, again, using a system that's been set up so that the youth are contacted confidentially. To make sure that they're able to follow up on whatever the recommendations were and again, get their questions answered and have some help in reducing barriers because the barriers are many and they pop up all the time. The program that's being used being piloted at a couple of the clinics in Los Angeles County that serve youth in foster care is a navigator program where all patients who are 12 or older get oriented to the navigator role, even if they're not there for sexual or reproductive health care. And they get an introduction and some concrete examples of ways that the navigator might be able to assist them. And that increases the possibility that they'll actually be able to utilize the services. So we want to create a welcoming environment. And again, this idea of being equitable means that a welcoming environment welcomes all young people. So these are some things to think about in your clinic environment. Is there a multilingual non-discrimination policy that's inclusive of people with disabilities, BIPOC and LGBTQ individuals and communities and posted in the waiting room and in the exam room? So is it explicit? Have you looked at the language on your intake and history forms and questionnaires? Is it non-binary and gender inclusive? What's the environment look like? What's on the walls? Who are in the videos? What images are represented in health education materials? And do they reflect the diversity of the populations that you're serving in terms of race and ethnicity, sexual and gender identity, and sexual orientation? Do you have materials that are inclusive of youth with disabilities? So what's the visibility? And do you offer a range of health education materials and approaches that can really accommodate the youth's preferred language, their learning differences, and any access preferences or needs? So for example, if all your health education materials are on paper, in paragraphs, lots of words, written at a high school level, that's not going to meet some of your patients' needs. And you need to make sure not only is it in the correct language, but are there other ways of accessing the information? Fewer words, sites on the internet, interactive sites on the internet. So really looking at the range of ways that people learn and making sure that they have information that's actually accessible to them. So, and then the third pillar that we want to emphasize is that these services need to be effective, which means that they need to be trauma-informed and healing-centered, strength-based and resilience-focused, client-centered, and developmentally appropriate. And I'll go through each of those, but I want to read this quote to you and we'll go from there. I would say what makes a clinic perfect would be the communication, understanding, and the services that are provided, the support, the continuing support. I would say support would be the biggest thing. You just want to feel comfortable speaking about what you're going through and feeling that we're here for you. We're here to support you and your needs and to make sure that you're safe and healthy. So anything else really doesn't matter. I'm not here to judge you or anything. So I think that's what would make a clinic or a doctor's office so much more welcoming. If they had that energy of, okay, I'm here to serve you. I'm not worried about anything else but your health, and what is between us is between us. And really just giving that youth the option to be included in their own care, you know? So I could really stop the talk now and we would have covered it all, because I think this quote really says it all. This really is the perfect clinic to meet the needs of young people. However, I will go through these points in effective care. So every aspect of every interaction really needs to be oriented towards building trust, agency, and empowerment for young people. So this may be familiar to some of you. I think, again, probably everybody who's at this conference has a good grounding in what trauma-informed services mean. These are the 4 R's of trauma-informed care: that you realize the widespread impact of trauma, that you recognize the signs and symptoms, that you respond by fully integrating the knowledge of trauma into policies, procedures, and practices, and that you consciously, actively resist re-traumatization of your clients. And so, for example, sometimes the question of should we be doing ACEs screening comes up. Well, by definition, young people in foster care have experienced adverse childhood experiences, and making them retell their story, revisit these issues can be re-traumatizing. So you need to think carefully before you make those decisions. And then this is a really nice graphic from Trauma Informed Oregon that talks about the foundations of trauma informed care. And you can see again that you need both a commitment to trauma awareness and an understanding of the impact of historical trauma and oppression. And again, in policies, procedures, and practices, creating safety, trustworthiness, boundaries, transparency, predictability, and very importantly, choice. Restoring power through choice, empowerment, a strengths perspective, and skills building, and building self-worth. And relationships is a really important part of building a sense of self-worth. Respecting your clients, expressing compassion, being accepting and non-judgmental, investing in the mutuality of the relationship, and collaborating with the client rather than doing things to or on them. So when we talk about strengths-based, healing-centered, and resilience-focused, this is really a perspective change from what's wrong with you to what happened to you. That's kind of trauma-informed care, to really what's right with you, what's going right, what are you proud of, what do you feel good about, what do you want to share with me? Healing happens on 3 levels: on the individual, interpersonal, and institutional level. And healing really centers on the intersectionality of culture, race, and identity, on the critical need of youth to be supported in building a sense of agency, the importance of really nurturing a future goal orientation, and couple that with the supports that youth need so they can actually move towards achieving their goals. And again, this issue of relationships, the primacy of relationships, a sense of meaning, and having aspirations. And some of those relationships might be with you if you leave the door open to that kind of mutuality. So client-centered services have many different components. The most important probably is taking the time to listen and learn from your patient, building a partnership with them, and doing things with the patient rather than to or on them. That you're aware of potential barriers and you really seek to eliminate barriers and enhance the youth's ability to seek and utilize healthcare. That you take into account what's in the youth's control and what's not, and never be afraid to ask. If you're unsure, ask your patient. They're the expert. They can tell you. I can't do that because I can't get there. I can't do that because I don't have access to that. My foster parent won't allow me. I'm not able to leave school, whatever the issue is. But you really need to know what's in their control and what isn't. This also might reflect in terms of the quality of their relationships and whether they are being coerced or controlled in their relationships as well. You want to prioritize based on the youth's needs and concerns, their preferences and their requests, not run your agenda on them, and develop an appropriate range of referral resources for the population that you're serving. When you think about referral resources, remember that youth development programs, activity programs, arts, service, social activism, sports, a wide range of pro-social activities that young people can be involved in, those are potential referrals that can support a young person in building connections to the community. The most productive and acceptable referral for the young person who's isolated or depressed might be a youth development program where they really can find a sense of meaning and connectedness and an opportunity to contribute rather than a traditional mental health referral. Many young people who I work with will tell me, you know, I went to a therapist, it didn't help. I went to a therapist, I don't feel comfortable with that. And then often a provider will feel like, well, then there's, you know, I have nothing to do because they don't want to therapy. Well, lots of different things and activities and connections can be therapeutic. Nothing against therapists, of course. When you're engaging in client-centered sexual and reproductive health care, it should be based in the concept of reproductive justice. And this is a philosophy developed by a community organization called Sister Song that is defined as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children that we have in a safe and sustainable community. So if you start there, you're committed to building a sense of agency, voice, and choice with the youth. You engage in non-coercive and respectful interactions with young people and listen to their concerns, their preferences, and most importantly, their limits. So when you tell them that they can set a limit, you need to respect that limit. If they say, I don't want to do that today, I don't want to talk about that today, I want you to stop what you're doing because it hurts or I'm afraid or whatever, you have to listen to that. Because the most essential thing you can do is build a trusting relationship, and that means respecting limits. You need to be non-judgmental and unbiased regarding the pregnancy decisions of young people in foster care, not come with your own agenda of what you think they should do when they're pregnant, not operate on the assumption that they don't want to be pregnant, don't operate on the assumption that they were trying to avoid pregnancy. Maybe they have been, maybe they haven't been, but you won't know if you don't ask. And there's a wonderful approach to care, providing care called the shared decision-making model, which requires providers to really dismiss their own biases and treatment preferences in order to offer information about all options to the young person and support them in incorporating the health information into their own decision-making process. So rather than running our own agenda, making the decisions and trying to push the young person into sharing the decisions we think are right, listening to them, providing them with the information and resources that they need and the time they need to engage in their own decision-making process. So I'm going to spend these last couple of minutes talking about non-coercive contraceptive choice counseling, which is really this concept of voice and choice in action. So you want to start by asking about the contraceptive experiences that the young person has had in the past. Find out what their method preferences and concerns are. If they have preferences, they always have concerns. You want to know what's important to them in a method and what, if any, method they're interested in using now. What do they know about it? So you build on their knowledge and can correct any misconceptions. What questions do they have? And you take the time to answer their questions. You have the responsibility to figure out if they have contraindications to the method. Provide information about methods using a decision aid that's youth friendly, that's organized by effectiveness, and make sure that you know good resources for them to access interactive methods using the internet, because there's great method choice websites that are interactive where they can really explore information at their own pace and in their own way. You want to really explore with them what their barriers to contraceptive use and method choice might be, and discuss whether they're ready to make a decision today without pressuring them to make a decision right now. If they say, yes, I know what I want it today, then you want to facilitate method initiation during that visit if it's possible. So again, review any concerns they have, respond to their questions, explore their specific barriers to their specific method, and develop a plan with them to address those barriers. Initiate a method if possible using the quick start algorithm, which is a way, you can look at each method, the timing in their cycle, and whether they can start a method today, and then make sure you make a follow-up plan. If you can offer options of phone or telephone or a telehealth visit for follow-up, if a physical exam isn't indicated, that's really ideal. Again, it's hard for young people, all young people, and particularly young people who are living in foster care, to get to follow-up appointments. And make sure you discuss with them and problem solve with them how to refill prescriptions, get their supplies, etc. If the answer is no, they're not ready to make a decision, ask them what they need in order to make or follow through on a decision, and then base your intervention on their needs and their concerns. Maybe they need time to think and process and explore other options or consult with people they trust. Maybe they need more information, or they need time to really look at the information in a different way. They might want to come back with a support person, especially if the method requires any kind of procedure. They might prefer to go somewhere else rather than seeing you for their method. And make a concrete follow-up plan. Find out what role, if any, you're going to have in facilitating their next steps. agree on what steps the youth is going to take before follow-up, and then schedule a follow-up appointment if that's appropriate. If not, support them and help them if they want it in finding a place they want to go for their care. Finally, care needs to be developmentally appropriate, because obviously a 13-year-old, a 16-year-old, and an 18-year-old, they may be involved in the same behaviors, they may need the same services, but the way in which they access them and can potentially benefit from them are developmentally distinct. And also normative developmental differences at different stages of development may be off a little bit. They may be, the youth in foster care may have really a unique developmental trajectory because of past or present trauma, interruption in the caregiving relationship, and issues with attachment and lack of consistent, safe, and supportive relationships in their lives. So it's really essential that if you're providing services to young people, you be familiar with the stages of adolescent development and gear your interventions appropriately. And this slide just shows, this is a slide that we, information sheets that we developed with LA Rep that give the developmental characteristics and some conversation starters around sexual and reproductive health for early adolescents or tweens, transition aged youth and young adults. I'm sorry, these are out of order, and middle adolescents. So this is something that you can access and look at. So I'm going to close by just talking about what's coming soon. So we have been developing a new resource for systems providers and staff working with youth in foster care. And the resource includes both a practice guide, which is very in-depth, that takes time to read and digest. It's all evidence-based and cited, and is an important resource on how to really learn over time to provide radically different type of healthcare to youth in foster care. And then a toolkit that has concise, graphically appealing tools that give you ideas, guidance, and support, and can really serve as quick references. So just to give you a quick idea, these are some of the things that are in the foster-friendly sexual and reproductive health care provider guide and toolkit. So you can just glance over this and see that we go into a lot of depth about how to, about the law, first of all, how to create a welcoming environment in all aspects of the visit, how to use a healing-centered, trauma-informed approach. Again, a lot of detail about the impact of trauma, strength-based communication, environmental considerations, ways to approach if a young person is triggered and having a hard time at the visit, ways that you can support them in kind of getting grounded and getting centered and feeling less distressed, and also resources for self-care for those of us providing these services. And then specifics about sexual and reproductive clinical health, clinical services. So again, using a trauma-informed perspective, how to do an interview, screening for human trafficking and reproductive coercion and intimate partner violence, how to engage in contraceptive counseling, pregnancy choice counseling, and sexual risk reduction in a non-coercive manner. How to talk about relationship quality, and then specifics about clinical services. So I want to just come back to these pillars of care and take any questions.
Thank you so much, Erica. That was a wonderful presentation. I dropped in the chat that it is time for questions, and we do have one so far. Somebody asked, will there be a mailing list to receive this resource tool?
That's a great, yes. So,
yes, take it from there.
The tool will be available on the LA Rep site as well as the National Center for Youth Law site. It will be fully downloadable. What we're trying to do, I mean, we don't really have the resources to make it beautifully internet functional, but it will function online so that you can get, you can click and get to the section that you want to see or want more information about, or bring up one of the toolkit, one of the tools. But it'll also be printable if that's your preference. And again, we're hoping that some of the tools you'll want to print out and just have handy. So it'll be a great resource for those of us providing services, also for new hires, people coming into your services or program. And if you do teaching and training, it will be a good resource for your trainees as well.
Hi.
Thank you. Oh, did you want to ask a question?
I just wanted to say thank you so much for clarifying that staff do not need to go into the exam room and stay in the exam room with youth, because that is what we're told and taught, and that is the procedure that we're given. And it can be so awkward and uncomfortable in that moment as a staff when you're like, am I even supposed to be here? It feels like I'm not, and we're not.
Right.
Unless
right.
they explicitly want us there, we don't need to be in there. And that's really, really helpful information to have.
Absolutely. And I don't know, I'm not sure where it got started, but it is, I understand that group home staff often come and they really believe that they're supposed to be there. They've been told basically, don't let this kid out of your sight. And so it's really incumbent on the healthcare provider. But I think this can be also a good resource for those who are providing the home aspects of care as well, to really understand what is the law and what are their rights, because you know, it can be very uncomfortable for everyone, and it really impairs the young person's ability to get the services they need. I worked with youth in detention for 14 years, and you know, we were alone in the room with them. You know, I don't know how people got the idea that you can't be alone in the room with a youth in foster care.
Mm-hmm. Thank you.
Anybody else have any questions?
Thank you so much for bringing up that point. We have one more question that I see right here. Somebody asked, is the resource that you just talked about applicable to providers across the country?
So that's a great question. It's something we really struggle with. So everything except the law is. When you write anything that includes the law, because it's state law, minor consent and confidentiality are state laws. And so it is written from the perspective of California state law. But the bulk, and you know, of course, there's a lot of overlap with other states as well, but the bulk of the material would be applicable to anybody who's providing care for youth who are living in foster care, or youth who really have experienced trauma in their lives.
Awesome. Thank you so much, everybody, for joining us. Big thank you to Erica. You rocked session A. That was awesome. And it looks like at 12 p.m. we will all transition to a lunchtime. So yeah, thanks again, everybody.
Okay. Thanks, everybody. I really appreciate you attending the session.